All right, we should be good to go.
All right. Hello, my name is Cindy Kraft. I'm one of two owners here at K&K Healthcare Solutions, and my better half and co-owner, Sherry Teague, is not able to join us today, unfortunately. We miss her terribly, and we absolutely want her back for the next one. But because of that, we're going to pivot just a little bit today because we want to cover the questions that we've received ahead of time, but also give you the opportunity to add some as we go. But I brought in some reinforcements. One you've interacted with before, Scott. Although you may have only noticed him as doing the technical part of these meetings, he is our manager of client services. And he helps agencies as they onboard with our outsourcing services. He provides technical support to our internal reviewers. He does OASIS reviews. He does all kinds of things. And so I thought, well, he tends to be in the background on this Q&A. Maybe we just pull him up to the front and get him a little bit more involved today. I also brought Adam, who is our QA manager for OASIS. I know a lot of times we get questions related to OASIS, and lately both he and Scott have been involved in some auditing, some educational related activities, and so I thought they might have some insights that this group may find beneficial. So hearing some different voices this time. Also, I guess selfishly, I highly doubted you just wanted to hear me sit here and read questions and answer them all, because Sherry provides that lively banter that I think makes this an enjoyable hour, at least for minimally for me. I like that back and forth piece. So as always, you have an opportunity to put your questions into the box as we go. I see someone has already put a question into the meeting notes. We also have the questions that have been submitted ahead of time. And so with that, Scott, we want to make sure we're able to go through the hour efficiently. So fire away with the first question.
All right. The first question has to do with missed visit documentation. This person asked, they know the new regulations has several new timepieces, but my question is related to the notification to the provider. What exactly needs to be included in the communication to the provider versus documented in a clinical note?
So I will try to keep my answer concise because we have the direct question and then we have some issues that relate to it. And those of you who have participated in our previous Q&As know we try to answer not just the question, but maybe give some contextual thought as well. When we think about a missed visit from a technical sense, it really is an alteration in the plan of care. So the skilled discipline did their initial assessment. They projected that they were going to see the patient this many times per week, and now that did not happen. So however we communicate to the physician now about an alteration in the plan of care, we are to let them know that that visit was not made up. So the first thing becomes if it's an early in the week missed visit, we should really be making every effort to reschedule that during the week. If we're able to do that, it really doesn't matter unless there's specific orders for, let's say, a particular wound care that it has to be Tuesday, Friday. That can throw a little bit of a wrinkle into it, but more often than not, twice a week is twice a week, 3 times a week is that, and we can try to move that around. We know that if we fix it that way, we don't even need to let the physician know that there was an alteration in that. I think it's important not just to let the physician know that a visit was missed, which changes the plan of care, but I think it's good to mention the reason, which leads me to my next piece. I see a lot of patient refused, patient refused, patient refused. I think we could do a little bit better in exploring what's going on with the refusal. Is this patient overwhelmed? In general, are they overwhelmed with the number of services? Are they overwhelmed with what's going on with their disease process? There's a lot more, I think, behind refused than just putting those two words down and leaving it at that. I think we should also look at it in terms of that alteration to the plan of care should have consequences. And I said should carefully because I want you to follow my train of thought here. When that skilled professional has outlined that this person should be seen, let's say, 3 times in a week, that is my professional opinion. I believe that that is the intensity we're going to need to meet the intended outcomes for care. I have a patient who misses one of those visits. Okay, so now instead of 3 times this week, I've only seen them twice. The very first visit after a missed visit really should contain one of two things. Some documentation that indicates that missing that visit had consequences, that maybe I was unable to reinforce something I needed to reinforce. Maybe we have an issue with a piece of equipment. This may have set us back a little bit with respect to some of the teaching, because now instead of the 3 times, I was only able to see them twice. So this is what it means when there's an alteration in the plan of care. The only other option is missing a visit doesn't matter. I'm going to pick up and do the exact same thing I would have done regardless. And there's nothing going on affecting the care plan because they missed a visit. And if that's the case, if twice a week is just as good as 3 times a week, then you need to really consider dropping your frequency to twice. I'm not sure we're really thinking through what our documentation looks like more often than not now, which is I recommended 3 times. Oh, missed visit, patient refused. Then we go back, no harm, no foul. Another missed visit, patient refused. Another missed visit, patient refused. And then we go along and patient achieved goals and we discharge. If the patient can do just as well with fewer visits, why do we have the higher intensity? So I think the issue of a missed visit has multiple factors to it, and we need to keep it in the context of it's an alteration to the plan of care. I need to let the provider know that what we planned is different, and I need to seriously think about, does missing a visit impact what I've been doing with this patient? I'm not saying we're trying to make the patient look bad, but this kind of off the cuff, miss a visit here and there is no big deal, doesn't really speak to medical necessity very well. And I think we're hesitant to say things like, I was unable to advance the exercise program, here's my PT is showing, because we had a missed visit. We're like, I don't want to put, but that is your professional opinion. If it's clear that you have possibly slowed our progress because of cancellations, I want to document that. No different than if I do my assessment and believe you should be seen 3 times a week and the patient says, absolutely not. I don't want you here more than once a week. Well, I'm not just going to put 1 week 4. I'm going to put that in the order, but my documentation will clearly state my professional recommendation was 3 times a week. The patient is only agreeable to once, and I think this could affect our plan down the road. This could make it more difficult to achieve desired outcomes. Same thing if the patient says, I don't want OT. Okay, patient refused is what I see in the document, but is there a consequence to that? Do we see potentially more problems with their ADLs or inability to fix those or remedy that situation because of the cancellation? So short version, it's a plan of care alteration. We need to communicate to the physician that this has been a change. I think we need to add a reason so they understand what's behind it. And it wasn't just we're short staffed and so we just didn't go. But our clinical documentation really needs to dig a little bit deeper into the why and the consequence for that.
All right. The second one has to do with, and thank you very much, everybody. I am monitoring the chat. If anybody else is having issues with audio, please just put it in there. I may have a solution for you. I will also be looking at the chat for any questions in regards to the that you added that we don't have that were submitted beforehand. Some of these are, if you have follow-up questions, Cindy, how do you want to follow that up? Like if it's a more clarification, for instance, somebody just put in one.
I see that. Let's go ahead and take that one because we're on the same topic.
Okay. Yep. So when missed, often due to a daughter or family member visiting and assisted, not always predictable, not something we can count on, but it does happen. And the patient doesn't want to reschedule and have an extra shower this week. If the aide visits and MD has told us they do not feel they need to know when the patient declined that sort of visit, but there's no exception on the type of visit. So I get a little bit more nuanced look, but is there anything that would change in this? What would you say?
Well, I think the undertone right there at the end is an important piece. Do we really believe the physician actually cares when they miss any visit? And it's a safe space, and I know we're recorded, but I think fundamentally we could all agree most likely no. They tend to refer for home health. Here's the services. Yep, I signed the plan of care. Please let me know if anything's wrong, but I'm really not interested in micromanaging your episode. You do you, get them better, have them not calling me on the regular basis or coming into my office and everything's great. The thing is, that model has been in the past a little bit more freewheeling in our space. That's before the face-to-face, before other requirements, before rules get tighter. And the rules get tighter because the physician is being compensated by Medicare financially for care plan oversight. So if Medicare is paying them to do the care plan oversight, then they need to be more engaged than just kind of writing orders. I remember when I started in home care, they could write orders that said home health. And that's all the order had to really say. And you could figure out which services and all the rest of it. But now that issue of, well, it doesn't separate out if it's an aid visit versus a speech visit versus no, because if this was the signed plan of care and the projected number of visits and those visits aren't made, it's not really about does the physician want to know, the physician is responsible to know. So yes, we send them the information. Does that mean that they sit there waiting every day to see if there's a misfit? No, but we have the paper trail that said we did inform the provider of this change. Specific to the aid, though, yes, that does happen. That you have a family member who maybe is visiting for a week or two and they take over that shower activity, but they don't actually live with that patient. And so they're only there temporarily and then the aid needs to resume once they leave. What I just said is what we need to be documenting. We can put the aid on hold. If it's going to be for a week, they're going to handle this activity. If they've been there for the weekend and did one, and now the patient's like, I don't need an extra as described in that scenario, we can document that and we miss a visit and this was already done by the daughter. Absolutely, you can do that. But I think it's important that we're clear that in that case, very often what I see again in the documentation is patient refused. Well, okay, the patient refused in your example, but it's because the daughter was there and the daughter helped them this time or family member helped them this time. Well, then that need is still being taken care of versus a patient who is refusing an aid and isn't having somebody else do it, which could now cause issues with skin integrity, hygiene, and other types of things, especially if this becomes systematic.
And one more little follow-up to that. Is there any requirements on the timing of this visit notification?
We really should be letting them know as soon as possible. I'm not at the top of my head, Scott, and we do this very carefully in these Q&As. I do not have a CMS source at top of mind that specifies exactly when that has to be submitted. Timely is what I recall. I'm happy to look into that further if we need to do so. But ideally, we want that right away to let them know that that visit did not occur. I would say that if you were notifying them a week later, that's risky because typically what I've seen in my personal experience as a care provider, that missed visit notification documentation was all completed that day because that's when it happened. I took care of it right then because I knew they canceled on me.
Okay. Again, if there's any follow-up that we can't get you some information, reach out to us. We have people that love to look into this stuff and may know it off the top of their head, so we can try and maybe get that to you in an email. So.
And we never want to take a shot in the dark guess because we do not want to create risk in organizations.
Absolutely. All right. So the next one has to do with the medication classifications on the Oasis. So would the GLP-1 medication, so your Ozempics and such, be considered a hypoglycemic for the purposes of N0415 on the Oasis?
Hi, this is Adam. I'm taking this one. So that's kind of a yes, no question, but I have a slightly longer answer. I'll try to not make it take too long. But in case anyone needs a reminder, CMS does not generally decree. There's no official list of what they consider all the medications in those different categories, with the exception of, like antiplatelets. They did specifically say aspirin's an antiplatelet, but generally speaking, they defer to other sources for that. GLP-1 it's a hormone that it triggers both insulin release and does when blood sugar is high, it inhibits glucagon production. So yes, I would say it's a hypoglycemic. I consider it a hypoglycemic. And don't see, I don't see a solid argument in the other direction. But if we really want, if it gets down to, please tell us CMS what to do with GLP-1s, anybody can submit questions directly to CMS and possibly get that answered in one of their official quarterly Q&As. But because of the mechanism, like I said, it triggers insulin release and inhibits glucagon production. So I would consider that a hypoglycemic. And I do have a source I'll be putting in the chat, a paper that you could find at the National Center for Biotechnology Information. If anybody's curious, if you'd like to do further reading.
But Adam, why did you mention the aspirin?
I did sneak that in there as a bonus
You
fact,
mentioned
just because
it, but I know that that's a bit of a sore spot for you. So I'm going to poke the bear a little bit about why'd you throw aspirin in there on a hypoglycemic?
it's just one that still comes up that we see in reviews where it gets missed, where it's not being accounted for in N0415. Aspirin is considered an antiplatelet and should be accounted for in that item. So yeah, I did just take a shot at that. But it also serves as a good counterexample, the exception proves the rule sorts of thing. That's an outlier for, as I was calling it, a CMS decree about drug classification. Generally speaking, they don't do that.
Well, and that's an interesting piece to that in the guidance, because most of the classification ones they stay out of, and I am personally grateful, because if they were going to maintain that list, it would have to be accurate in real time, which I don't think they have the bandwidth to constantly update that based on when new medications come out. So there's always going to be this new med, this new drug. We look to the resources that we have available. And ultimately, like you said, Adam, if it's become, I'm still not comfortable just going off of this, I need a thus saith CMS, then we absolutely can use that Q&A function.
Kind of with that as well, and a little bit, there are some other guidances too that would constitute when you don't select answers, like you mentioned antiplatelet, but we're using a heparin flush would not be considered being used in an anticoagulant because that's the only thing it's being used for. That was in one of the guidances as well. So there is a few little tweaks, but the aspirin one is the one that gets missed probably the most that we see. Yeah.
Yeah, I agree with both because that and also they would be slow to react. The wheels of bureaucracy are slow to react to new medications and things like that. So I always just go into, something new hits the market, do some research and see how it acts. And to me, that's a fairly cut and dry one.
Yeah.
But it's an understandable question because most of the OASIS has a more direct, what does CMS say about this situation? And the answer for a lot of medications is kind of just looking up how the medication works.
Use reputable sources.
Yeah.
Right. So the next question we have has to do with discharge OASIS. And I see that we also have a question regarding the transfer and discharges in the chat. So maybe we'll start with this one, and then this kind of ties into that. So in discharge OASIS, if you have an unplanned discharge and the last qualifying clinician is on a leave of absence, and then the next qualifying clinician is also on a leave of absence, and the last qualifying clinician the next qualifying clinician for this was 4 months ago, who does the no visit made discharge OASIS? So this is pretty much with following the rules of last qualifying clinician. What would you say is probably the guidance for this?
Well, I'm going to take a little bit of a different spin with this than I typically would. We see pretty regularly variations on this theme of the non-visit discharge. And we've talked about it in previous Q&As from the vantage point of CMS clearly intends that the non-visit discharge is a rare occurrence. Much like the use of DASH in OASIS, they always disclaimer the DASH with, we don't want you using this a lot. The same is true with the non-visit discharge, that it was never intended to be a regularly occurring phenomenon in home health. And so when we run into situations of an unplanned discharge, I've seen questions about, well, the clinician started the OASIS, was then in a car accident, can't finish the OASIS. I mean, I'm sorry, the clinical brain in me worries like, hey, that's a great question, but what happened to is the clinician okay from the car accident? We see this in the Q&A cycle repeatedly with, this person left and then this didn't happen and then this other thing didn't happen. What was very interesting in looking at the guidance manual for E2, whenever they change the manual, they change instructions, not just embedded in the items themselves, but a lot of that stuff about time points and who does what and when they can do it and sequencing these types of things. And I think based on the number of Q&As over the last year, E2 has a ton of highlighted in red language trying to address the scenarios about the non-visit discharge. I would highly recommend, my response to this question is, please go to the OASIS E2 manual and read the red language about handling a non-visit discharge. They have tried to explain every scenario to the best of their ability in their official language, what you do in that situation. So I think that is the best and most reliable source to find your answer to this question to any time we're in a non-visit discharge situation. But it really is meant to be an extreme circumstance type thing. When we do auditing of discharge OASIS, there are times where there seems to be an abnormally high number of these non-visit discharges. And very often they're labeled as the patient refused the final visit. We have to consider that the non-visit discharge creates risk in relation to our outcomes, because it was never intended that it's some sort of rigged up, what can I do, back up to the most recent provider and all this other. They gave us that option as a worst case scenario, here's how you handle it. But I'm beginning to think that our staffing situation is affecting this as well. And so I would recommend agencies look at the frequency at which this non-visit discharge is occurring and the reasoning behind it, and may need to consider different scripting for clinicians around this event. I believe that if in the visits leading up to that, we were very clear with the patient that our final visit will be on this day, what we are looking to do is a final, complete, comprehensive assessment, just like we did at the beginning, because the last person with you wants to make sure we've not missed anything. So there's a lot of questions involved in it, but we want to make sure before we sign off that you graduate and you're free, little birdie, that everything that needed to be taken care of was, and that you are set up for success. I think that when we call a patient and they know it's the last visit and, oh, I'm going to come today, and they say, oh, honey, I don't think I need it. I'm doing really good. There's a temptation to look at your schedule and go, okay, freed up space, either to take another patient, to get caught up on something else. And we kind of cavalierly let that one go. Again, that was not intended to be how this worked. And so I would strongly recommend you look at how often this happens, because there may be some underlying things contributing to it that could ultimately be showing up in your outcomes.
All right. In regards to discharges and transfers and everything, it's on this, but it's not in regards to the no visit. But it says the question is about CMS states that on transfers and discharges, you have 5 business days of when notified of the transfer or discharge to notify the provider or facility to provide a handover of care. Now we are deemed by Joint Commission, who state we only have 2 business days to provide. What are your thoughts on the discrepancy? Is there been any more clarification on that?
Well, I think there's multiple issues being rolled into one, because discharging a patient, a planned discharge, there really isn't a handoff to another provider. The only thing we have within the OASIS talks about the medication piece, and that is more about transfer of a patient to somewhere else. The issue of being, when we're notified, is with respect to the 2-day issue comes into play of, we have 2 days from finding out they were admitted to a facility to work on that OASIS piece. So I'm not quite understanding where Joint Commission is getting into 2 days to notify the provider for both the transfer and the discharge. Those are two very different situations and may not involve a subsequent provider. So I would ask the question asker to use our mailbox address at the end of the presentation, and you know it because that's how you registered for this today. I think we need a little bit more clarification on that situation, because right now I'm not quite understanding Joint Commission's position on this, or what exactly is the case of notifying the provider, but we can get back to you on that one.
Yeah, I just also want to let everybody know, sometimes as people are getting some tech issues, sometimes if there is more clarification on a question that we covered earlier, by all means, this is being recorded. It'll be sent out. Go through if you missed it and see if we've answered it. If not, go ahead and, like you said, at the end of this slide, we'll have the link to our how you can communicate to us. Reach out. Maybe we can provide a little bit more clarification on that. That being said, the next question has to do with joint visits. Is it acceptable for PT and OT to make joint visits at the exact same time and bill for both disciplines when it was a patient that did not necessarily need two clinicians to co-treat? I.e., PT does lower body exercise, and when the patient is recovering from that exercise, OT will do upper body. More frequently, the patient is requesting both therapies together, and the therapists like it because they have another person for safety and they don't have to ask the patient the same question over again, increasing the patient's satisfaction. What are your thoughts on this?
We're going to take this in two parts. Can you do co-treat visits in the home health space? Yes. They don't always have to be two therapies. It could be therapy and nursing as well. But in the technical sense, you can do that. The issue is you have to be able to demonstrate you were there for two different reasons. You cannot have another discipline there as a second set of hands. You can't have it, I mean, it needs to be so that the activity we're working on collaboratively with this patient, I am able to differentiate my physical therapy part of this, and OT is differentiating their occupational therapy part of this. It can't look like it was a convenience issue, or I'm a little concerned in the example about the idea that it said the patient did not necessarily need two clinicians to co-treat. So when I think about a necessary co-treatment, back in my career, the best example that comes to mind is we had a patient with significant balance and mobility issues in a wheelchair, and speech was wanting to see if they could get better voice production from a standing position, and clearly they were not going to wrestle them into a standing position. So we would co-treat, and I would work on getting him up, getting him properly positioned, hands on the counter, safely standing, and working on standing balance, when she was also concurrently working on the voice production from this position to assess if that was making a difference in that case and what needed to be done from that strategy. So it wasn't that we were both boosting this patient. It's not about just having a second set of hands. She was clearly there assessing the situation from the voice production, and I was working on balance in terms of the standing piece. So it may just be a wording issue of the question, but just because it's convenient, we would have to be extremely careful about how we're documenting this. So if it is, I'm doing PT stuff, and then while you rest, you're doing OT stuff, then you're not actually resting. And I would imagine that that might be a more unique situation. You would have to be extremely clear in your documentation with respect to time overlap, because your start and stop times absolutely should overlap. Yes, I am emphasizing that because I've seen clinicians say it's a co-treat. Let's say it was an hour, and PT puts the first half hour and the other therapist puts the second half hour. You can't do that. You were there the whole time. Okay, so trying to split the clock starts to make this look suspicious because you were there longer than that, so was the other one. I think if we're very transparent about the patient-driven reason for this, we're very clear that we both provided skilled care, and there was a reason for it to be done this way, we can do it. I'm just a little apprehensive because they like it, because it said we don't need it, but then it was a second person for safety. Well, if you felt you needed a second person, then you have a second person for a safety concern. Does it need to be another therapist? Because we can't just have another person there for just a second set of hands. So it's a little bit more complicated by the question wording. What I want the takeaway to be is, yes, you can. You need to honestly report start and stop times, be extremely clear, the medical necessity reason each one was there, that the focus of what you're looking at is different. It can't look like we were both there to do the same thing.
Yeah, and in regards to that, we actually have somebody that says their PT and OTs do occasionally co-treat. It's known issue in the home. It's done when they need to come up with plans that don't violate each other's plans related to what they simultaneously see, usually for a very difficult patient or environmental situation and stuff like that. So that kind of goes in with what you said, where they really need to discuss, collaborate, so that way this gets done in a way.
And the devil's in the details, Scott. The documentation needs to support that description, because it just can't look like this is a very difficult, involved person. I can't transfer them myself. I want OT there with me as a PT to do the transfer. Did you need it to be OT, or did you just need a second person? If this had been a hospital situation or a SNF situation, you would have grabbed an aide. Then you can't justify just having OT there to be the second set of hands. There has to be an OT reason that they're participating in that treatment session. So that's where we got to make sure we're really clear in the documentation. And I can't say it enough because I've seen it too many times. Don't fudge the time in, time out. It just makes it really weird from an auditing standpoint to say, how is this a co-treatment when you claim you were not in the house at the same time?
Yeah. Well, we did just get another question in the chat box, one I can actually answer really quickly, and then we have a second question, which will kind of give a nice little segue into some news from the K&K side. So, first question is an implanted dialysis port considered a surgical wound? If so, is it always considered a surgical wound, even if they've had it for years? How do we document this? Yes, guidance is dialysis ports, dialysis fistulas, any centrally implanted device like that is considered a surgical wound as long as it is in the patient's body. That has been, I've been ever since C, that I can remember. I was not here for the ones before that. But it is always, yes, you would document that under 1340 and 42. Presence of surgical wound and status of. Yeah, as long as they are there and being like that, they are considered that. The other one is, do we have any good free resource or tips for clinician on how to write a good narrative? We have a lot of resources in regards to this particular one. I'm not sure, but we have been around. We have just hit a little milestone for us. We've been doing 13 years of serving the home health industry. And with that, we have a lot of recordings, a lot of blogs, a lot of newsletters. You've probably gotten probably 3 as we started this QA. But we are constantly making those, and many of those are put out into the wild for you to be able to use. We are always backing them with verifiable, like when we make a claim on something in regards to guidance or anything, we are always citing where that comes from, as well as bringing up stuff that is in the possible future and letting you know that it's not there, but keep your eye out. But if you want to scan this QR code with the little dinosaur in the middle, let us know if there's if you have a story about we've been around for a long time. This is what happens when you let me start talking. Is I won't be quiet. But
if I can circle back, Scott, about the narrative note. We
Yeah.
do have content about that on our YouTube channel. I know Sherry's big on reminding folks we have a YouTube channel where our unfiltered productions end up. Our version of a podcast, which is usually Sherry gets me riled up about something and then hits record. But we have talked about narrative content on there. We do have a webinar. You could argue it's a little old date-wise, but the content is no different. We highly recommend consideration of the SBAR format. I think what's happened with the narrative note is we've lost focus. I don't believe that the skill level we have from our nurses and therapists in home health, that they can't answer the question, what is the focus of care? When we audit records and it says the focus of care is, you've seen they've tried to team it up in the EMR and they leave a blank and it's still blank. Or the focus of care is XXXXX. Clearly, you're supposed to put something in there and it still says XXXXX. I don't believe that there's clinicians that don't know what they're doing. I think clinicians have gotten a lot of mixed messages about what is in a narrative summary, about really being concise. This is about why are we here? What are those relevant comorbidities that we're going to be dealing with over the course of care? What are we going to be doing for this patient? What do we expect the outcome to be? I think a lot of it is somebody told me it's got to include how I found the patient. I still hear that. So it'll start, upon entering the home, the patient was seated by the door, by the with the sun shining in, and then there's the dog. Okay, no, because somebody told them once you have to describe the location you found the patient in. There is no current regulation that says anything about giving a detailed description of where they are when you first lay eyes on them. Or a lot of upon entering the home, blah, blah, blah. Oh, okay, unless that's relevant to your plan of care, I'm going to assume you got in the home to provide the care and really should only be talking about an exception if you couldn't get in the house. So I think there's just been a lot of myth and back and forth around the narrative that we need to just get it back down to this. And I think one of the biggest issues I see is viewing that summary as cut and paste things I put in other parts of the assessment and just repaste all this here. So you already said that over there, you said that over there and over there. Taking those three, cutting them and all just dropping them in here is not an actual summary. So it really is about, let's get back to the basic things. What is the focus of care? What are those relevant comorbidities? What is your plan? Because I think the narrative, quite frankly, is often a missed opportunity, even in the follow-up visit notes, of giving your professional opinion. How well do you think this patient is going to do overall? On a follow-up visit, how well did the patient do today? Was this a good day or not a great day? Did the treatment go the way you planned? Were there things that maybe derailed it a little bit that you're going to have to revisit on a future visit? Really just giving that concrete direction, because I think what's happened is we either see 2 sentences that don't add value or 20 paragraphs that also don't do it. So check out those on our YouTube channel, but I think really a lot of it is recognizing we may have given too many variations of what we expect in a narrative note, and it's really just led to confusion, not deliberate. I don't know how to write one.
In the chat, we've got some more information on that joint commission. I want to say, I think this might be one of the better ones because it talks about the 2 business days, facility handover care. I think that might be best if at the very bottom of this QR, it has the knhelp.com/contact. Please send that to us. I would like to get you a more detailed and so we can look at that, because I think it's going to require a little bit more detail than what we can really go on in this format. But please reach out on that.
Now, Scott,
go
you've been handling all that stuff. I want to turn the tables a little bit because I have a question for you. You ready? So, as an OASIS reviewer, is there one item you wish clinicians would stop getting wrong? And I'm going to open this up to the attendees. Feel free to put that in the box too. What is one OASIS item you really wish you could just put to bed and the clinician never got it wrong again?
I would have to say the 1850, and I will clarify this. Ooh, haha, I already see somebody agrees with me. 1850, I don't think that's necessarily a clinician's fault. I believe, much like some of the other questions in the OASIS, being a discipline neutral data collection set, they're not written with a clinician brain. So when things like 1850, where it the way it's worded leads to confusion, um, the whole thing of, hey, one is if you needed a person and a device, or a device, and two is you need both. But the fact that they start including words like pivot, and that immediately every therapist is like, all right, what's a pivot? Or like, we know what a pivot, what do they mean it here? And that those don't necessarily align. um it, it's one of those I wish that would get right more, because that's, I believe, since the beginning, right? That's one of the ones that's been there since the beginning. I think I wish it would get reworded, because I get why people get it wrong, but at the same time, if I see it enough, I'm like, yep, I get where you're thinking here. Or they'll put that they're completely chair fast pretty much, but yet they're walking in 1860. So that's one. We've got one. So 1815, 1860. I would agree. Probably most people are like, it could probably do some rewording. A 1311. That's one. So now I will say, ever since they got rid of other, I wish they kind of worked on that one and kept 1350. But it's gone now. So it's so.
I think, though, the issue, your point, Scott, about the functional questions and folks picking those as well, I think the 1800s have just suffered from being old and tired. I mean, they're the exact same question for over 2 decades. And you look at it and go, can't you update this? I mean, we've reached a point, particularly on 1860, where the guidance doesn't even match the words in the responses. And I fully appreciate when clinicians are just like, okay, I understand what you're saying, but why does it use the word pivot? Why does it use one-handed and two-handed in 1860? Why can't they just change it? Just a reminder, the why is payment. Because these questions got pulled into the payment methodology we had before and retained their value, I guess, for PDGM, changing those responses is perceived to change how points would be gathered. It could, if there was further clarity, change how answers laid out. Considering adding other response options would absolutely change the points. And so the payment people at CMS have been very, very resistant to making any changes, because if you do, then you have to change things in the payment methodology, which requires all that math and everything else. And so that really isn't their priority. But I can tell you, on the value-based side, that has come up to say, well, then why am I doing GGs and the 1800s? That in our last technical expert panel call, they finally said they are moving forward with the ultimate removal of the 1800s to go to GGs. And I think when that happens, this is going to be better. The GGs give us, and I'm not saying they're perfect, but they give us at least a bit better scoring distribution than some of the weird stuff we've got in the 1800s. Now, I may or may not have asked that person if that was going to get done before I became a Medicare beneficiary. Yeah, they are going to, but they didn't give us a timeline. So yeah, I really wish it was yes, and it's next year, because I see somebody said, did they say that correctly? Yeah, they did. But because doing that means they have to reconfigure how function affects reimbursement, it can't exactly turn on a dime. But that is the first I finally heard official people say the move is to get the 1800s out. Now, I could be a beneficiary receiving home care by the time that happens. I don't know, but I'm taking that as a step in the right direction. But whenever you're dealing with data collectors that are like, I'm so sick of this. Why did the words say that? Why do they? It's not a cop-out. It's the truth. Because those are how they factor into the payment calculation, it's not quite as simple as reword it, add some different answers, fix these things. But I totally agree, looking at the same question for over 2 decades and going, if you just pick different words, it wouldn't be so hard. It wouldn't be so confusing. And I appreciate your guidance, but it doesn't really match what these words are. There's an end in sight. I just can't say based on their non-answer how long that's going to take. But since we're talking about function, Adam and I have been involved with a lot of OASIS stuff of late. And despite my 2 decades of ranting and raving about OASIS accuracy, I thought you had an interesting perception there, Adam, on some of the answer distributions in those M items. Because GG has the standardized guide across the board, but M 1800s sometimes have 4 answers, sometimes have 6 answers. I want you to share that with the group because I hadn't thought about it that way before, but I think it might help some clinicians.
Yeah, that's kind of what I was hoping was that, I can go on my own little rant. I'll try to keep it concise, but then hopefully, as long as at least one person goes, oh yeah, our brains are on the same wavelength, that might be helpful for me or people in my office. The GGs do make them look worse by comparison with that nice standardized gradient of numbers. But I think we've all sat through OASIS training and we know what the guidance says, but there's like there's the monkey brain, right? The humans, there's all sorts of studies about, psychologically what happens when you have to pick items from a list. And so I think sometimes, because we're always still seeing the same recurring issues with 1800s, I think that there's a part of us that wants to infer that there's like a linear gradient to the answers. So say like 1820, part of your brain subconsciously wants to treat it as your options as no help, some help, more help, lots of help. And that's not what it is, right? The answers are looking for specific things, and some of them are looking for much more specific things than others. They basically did the equivalent of sort these balls by color into these buckets. This bucket's for red, this bucket is for blue, green, purple. And okay, sure, that rule makes sense. I understand what you're saying, but that feels like a weird way to sort. So to just keep rolling with 1820, you have independent, set up a cleanup assistance. Then you've got the big umbrella of assistance, and then unable to meaningfully participate. So that's kind of, I'm not going to say, because it's not correct to say like everyone should be a 2 or like treat 2 as some kind of default. But when you also factor in the fact that this is not a general sample of the population, but patients receiving home health services, you're going to see an uneven distribution of answers. You're not going to see 25 when you look in aggregate at a large volume of charts. You're not going to see 25% zeros, 25% threes, for example, right? And there's also that whole element of you see multiple patients, you score 1 at 2 because they need supervision. You see the next person and they need lots of help, substantial physical assistance. Feels like there should be a different answer. Feels like they shouldn't also be a 2, but that doesn't make them a 3 because they are able to participate. Same thing when you go into like discharges. I think it could be frustrating for clinicians to go, we got them better. They need less assistance. They're still a 2. Which thankfully that's where the GGs come in, and the GGs do a better job at that specific thing of they get a little more granular. But yeah, I'm working on some kind of visual thing in the future for PowerPoint type applications. But yeah, I think there's like I said, we can educate. People have heard the guidance, they know the guidance. But there's just, that's kind of my just out loud rant. I don't know if that makes any sense to anybody else. Different brains, right? Everyone processes information differently. But yeah, was that helpful?
Yeah, actually, it brought up a thing as far as you're looking at it and you're like, oh, I can start seeing trends of why these are start going in. And those types of things we actually, trust me, with the new things that are coming out, especially the new Crush and the fact that they're trying to start targeting like reclaiming stuff for known things before payment occurs. It's really good for a lot of agencies to see and notice these particular trends and see if they can get it fixed before something happens. There's no longer I want to wait until we get an audit from CMS and then we have to go through TP. Like, it's better to know like periodically those types of things if that's happening on right now. How long has it happened? Stuff like that. So we do offer services where we are looking at specific things, documentation, how are your Oasis, is there functional, and we can tailor after that audit. Where is the educate? Are you doing great? And sometimes we've done audits where we come in like and we show you this is where you're doing great, and we think you are on the right track. You have a little bit of area for improvement, or you don't. But that's something like that. You can definitely, you can again, we're gonna bring up the little dinosaur. I think he's got longer arms than I do. But go ahead and scan that QR code or follow the link at the bottom. Again, this is being recorded. This will be sent out to everybody. Ask about our audit solutions. We have ones that we're looking at for, I know AI is a big thing in the space right now, and it's no longer, I mean, new agencies and stuff like that, or new EMR or old EMRs are bringing in new tools such as Home Care Home Base is bringing in something like that. There are questions and stuff like that that we can show you. Like, are you ready for some of the things that could put you at risk or not at risk for when those tools are implemented? Because although I don't feel that many of these tools are ready yet, they are being implemented across the US. So it's good to know where the risk is. So by all means do that. One of those things though, one of the risks we see, and um, for most people, I think the person um, um, is this for 1860. We were just talking about it. We have recently had a clinician questioning the recommendation to code M1860 as 2 when the patient is able to walk a very short distance, more than just a few steps, for the purposes of a transfer. Independently, even though the patient does not need supervision to walk for even though the patient does need supervision to walk for majority of distances on level surfaces. When we have advised that if PT does not need to assist or supervision at all times, M1860 should be coded as 2 for intermittent assist and supervision. Can you confirm this as correct?
So when we look, this is a great question of the response options don't necessarily tee up the guidance. So we know that the guidance has been clear for quite a while that the difference between a 2 and a 3 as is exactly what was described at the end of the question, intermittent versus continuous involvement of another person. So what I'm saying with a 2 is there are situations in which this patient is ambulating completely safe and able. I have absolutely no worries about them as they go room to room in their house. But if they're going to use stairs, if they're going to go out to get to their car and have to walk on their driveway or on an uneven surface, I want them at least supervised. That is saying we're good in some, we're not good in others. That supports a 2. If what I'm saying is realistically, someone should be at least around supervising whenever they're up and walking based on their fall risk, based on their homebound status, based on the fact they just got out of a facility, then that is response 3. So we clarified the guidance definition, but backing up to the middle part of the question. So when we're talking about at the beginning of care, let's say that this person is taking a few steps. The few steps thing has been a long debated back and forth in 1860. The CMS clarification, and it's cited sort of here, is that a patient who just moves their feet carefully as part of the transfer. So you get them up, they move their feet so they can sit in the wheelchair or they sit in a chair right by the bed. Those are not necessarily considered walking steps. And so you can consider that individual chair fast. But if they start walking in a direction, then they are considered ambulatory. So if it's the quintessential bed to chair, move my feet, you're not ambulatory. If it's bed, walk across the room to get in a chair, we have ambulation occurring. We can make our judgment about if that is safe or not, because sometimes there are patients that are air quote walking because their family members are sort of dragging them along, and we can say, yes, you got from point A to point B. Please don't do that anymore. Her arms might pop out of the socket. Chair fast. In the specific example, as a physical therapist, I'm having a hard time visualizing that somebody can take a few steps completely independently and safe, but then supervision kicks in only for everything else. I think the conversation with the clinician really needs to be around that shorter distance. Are they really safe and able? Are they considered at high risk for falls right now? Did they just get discharged from a facility? How are we saying that they're homebound? Because it feels to me that a 3 would be appropriate in that situation, because I'm trying to visualize a patient where I would say, Mr. Smith, up to 10 feet, you're golden. I'm going to close my eyes while you go 10 feet because I am not worried about you at all. But at 11 feet, okay, I need to be right here in case you fall. So could it happen? I'm not going to say never, but I would want to pursue that more about how truly safe is that for that short distance piece, and why would it change to the need for someone once you've gone more than a few steps? But I want to open the very beginning part of that question for a minute or two up to either Adam, Scott, both. Both of them are involved in doing our OASIS reviews here at K&K. How would you recommend handling, from either side, the reviewer side or the clinician side, if there's a difference of opinion about a recommendation to change an OASIS item?
I
What
can start.
suggestions would you give?
Well, the biggest thing is I would, if there's a difference in opinion, me being a reviewer, one thing is I like to provide the guidance directly from the manual on what it says, and then I provide some more information like what you said, to where I believe, because you're seeing the patient, you're in front of you have eyes on. I just want to give you a little bit more info of what this question is asking, and and how much safety, and with the falls risk and everything else. I just provide it from an outside of like, hey, I want to show you it's almost like a red button. So I want to provide you the guidelines, and how they are interpreted by their, and then that's where I leave it at. So, Adam?
I would agree, basically, yeah, just echoing the same. You two basically had the same answer. I mean, ultimately, there's the clinical judgment portion, especially when you're talking about outsourcing, right? The reviewer hasn't seen the patient. If you remove, I'm assuming the context for the initial question was this previous question about 1860, because removed of context, just the question of difference of opinion makes my brain immediately go towards, well, it's typically we're not in the era of opinion, and people need to, both sides are hopefully referencing the guidance, and you can come to a clear right answer. In something like this, where it's like, well, we are looking at the guidance, and this is kind of like, you really are ultimately getting it down into the clinical judgment zone, I think.
But Adam, what if, I'm going to flip the script then, because both of you are speaking from the reviewer standpoint and using the guidance, benefit of the doubt, and we see that someone has chimed in with provide guidance, speak directly with the clinician. Absolutely. But let's flip the script. What do I do as a clinician if I'm getting feedback that I know is incorrect?
You said flip the script. I would ask for that. Where are you getting these from? Because it's a lot of times we've seen even from our side of it, where guidance has been provided, but they're not reputable sources. So, and that is one of the big reasons why we here at K&K like to provide the same guidance regardless of reviewer, because I know how frustrating it can be, and I'm not even on the clinician side, that you're getting, both reviewers are saying you should change it, but they're both coming at it from two different ways, and you're like, well, which is better? Like, which is more like, so we might, if you're not getting consistent, you should be looking for consistent guidance, and be able to back up why. And if that's not in regards to where they're getting their information, then that's what you should be asking for if they can't provide that. But that's
clinicians should definitely be empowered to ask, source. right? Like
Yeah.
if that's not in the initial feedback from a reviewer, clinicians should absolutely feel that they can go show me where the guidance is for that. And as we know, the only source for guidance is CMS. Um, yeah,
I know we're getting up on time. I just want to let you know I have put up the final slide with our contact information. I didn't mean to cut you off, Sydney. I just wanted to let everybody, if anybody needs to, I'm here to stay whenever they kick me off because I get to talk. But I did just want to show that we do have that up, and happy belated St. Patrick's Day to everyone. So,
The only other piece I wanted to add, Scott, is I think from the clinician perspective, if you are challenging a correction, it's important that you use the guidance as well. I agree with show me. I also think a clinician, by utilizing the guidance, by reading the guidance themselves, may realize why that recommendation was correct on their own, or have a clear reason supported by that why they're not going to change it. I think there's times where corrections are just rejected outright or just dismissed without a reason, and that just ends up being counterproductive. But I will say, as a reviewer, we have to stick to that guidance because I've witnessed situations where the clinician is getting erroneous information, and if that trust gets broken, they can become quite belligerent about not accepting changes in the future, even appropriate ones. So that's why that source document, I think very often we think about how do I encourage the clinician to make the change, also needs to have an open door policy that if they disagree with the change, please show me in the guidance how you defend your position. Because I think sometimes when they're like, well, you show me, I don't like it anyway, the patient lives alone and told me XYZ, that is not what it says. Please, let's go back to the guidance together and come to a resolution. So I want to echo what Scott said. Thank you very much for participating today. We never get to every question that we want to, but we keep the door open. If you want to shoot us an email outside of one of these or send us a question you want to have on the next session, we look forward to that. And fingers and toes, and we're super excited to have Sherry back for that next one. And not saying anything about you guys. It was great having you on, and I'll probably have you on again in the future. But I think everybody missed Sherry's essence and energy in our session today.
All right. Thank you very much. Everyone have a great one.